Hey everyone, and welcome to this week's lecture on elimination and sleep-wake disorders. So we're going to begin today's lecture with the elimination disorders. And these are typically present in children that urinate or defecate in places other than the toilet. Children with these disorders are usually past the age where that is like acceptable or where it's kind of like a common behavior. Is usually diagnosed in children between the ages of 7 and 12. Elimination disorders primarily fall under enuresis, where urine is passed outside the toilet. Alternatively, and capricious is the passage of feces in unsuitable locations away from the toilet. In other cases, it's possible to experience both disorders at the same time. While there are some children with these disorders that act voluntarily, elimination disorders are frequently characterized by a lack of bowel or bladder control, meaning that the child may urinate or defecate on their beds or their clothing without intending to do so. This lecture will examine the two main types of elimination disorders um, and the common characteristics of each condition and some of the factors that are responsible for the disorders. We'll start with enuresis. Enuresis is commonly known as bedwetting. Children with this condition are unable to control their urine. This usually results in frequent or irregular release on their beds or elsewhere. In households made up of young children, especially boys, enuresis is very commonplace. Around 20% of 5-year-olds in the US live with this condition. The number goes down to 5 to 10% in 7-year-olds. It is bedwetting is, however, more common in the latter group age in 7-year-olds. So enuresis mainly occurs in two forms. There's the nocturnal only and the diurnal only. There can also be a combination of the two. So, of course, the nocturnal only is when the urine is released at nighttime, and the diurnal is urine incontinence happening during the wake hours. The nocturnal only subtype of enuresis, sometimes referred to as monosymptomatic enuresis, is the most common subtype, and that involves the incontinence only during nighttime sleep, typically during the first third of the night. During diurnal only subtype, it occurs in the absence of nocturnal enuresis and may be referred to simply as urinary incontinence. Individuals with this subtype can be divided into two groups. There are individuals with urge incontinence, which have a sudden urge of symptoms, and the individuals with the voiding postponement, which consciously defer urges until the incontinence results. The nocturnal and diurnal subtype is also known as the non monosymptomatic enuresis. During nocturnal enuresis, occasionally the voiding takes place during the REM or rapid eye movement sleep, and the child may recall a dream that involved the act of urinating. During daytime enuresis, the child defers voiding until incontinence occurs. Sometimes that's because of a reluctance to use the bathroom, and that can be because of things like social anxiety, preoccupation with school. You'll see it a lot with children and preoccupied with playing video games as well. These urinectic events most commonly occur in the early afternoon, on school days, or upon returning from school. There is no precise cause of enuresis. There are different factors that are, however, linked to bedwetting or passing urine in inappropriate places. For instance, constipation may increase pressure on the bladder, leading to an increased urge to urinate. And deep sleepers who are not easily aroused may also be at a higher risk of enuresis. Where the bladder suffers a delay in maturity, this can affect its capacity to hold urine as well. Likewise, there are levels of what's called vasopressin, which is a hormone that promotes water retention in kidneys, and that may decrease. This can impact the changes of holding urine in. Certain risk factors also increase the chances of enuresis, and those include unusual stress in children, growing up in a low SES socioeconomic environment, divorced parents, the addition of a sibling or the loss of a family member, and also a family history of enuresis. Next, we have encaprices. As a benchmark, encaprices occurs in children no younger than about 4 years old. Encaprices is characterized by children passing stool in inappropriate locations, like in their underwear. This condition may be voluntary or involuntary, and it's a common occurrence mostly in male children. About 4.1% of children between the ages of 5 to 6 years old will defecate in unsuitable locations. In 11 to 12-year-olds, this number drops to about 1.6%. Encaprices usually takes place in the daytime as well, and it may be observed in children that have received and those that are lacking toilet training. If we're looking at the developmental history or trajectory in an average amount with children, usually at around the age of 3 is when we'll see toilet training start to take place. Another cause that could be of encaprices is toilet training too early or toilet training too late. Encaprices also is observed in two forms. There is with constipation and overflowing continence. So in that case, constipation causes stool to be hard and painful to pass. The pain can prevent a child from going to the toilet, leading to greater difficulty in releasing the stool. And that strain caused by the feces can weaken the colon nerves. This can cause liquid or softer stool to leak around the yet to be passed stool. The child may also lose control of bowel movements. And there's also without constipation and overflow incontinence. This occurs when a child soils their clothing or inappropriate items without signs of constipation. This child will have bowel movements in unsuitable places or times. Two types, of course, have been described. There's the primary type, in which the individual has established fecal incontinence, and a secondary type, in which the disturbance develops after a period of established fecal continence. Encaprices can persist with intermittent exacerbations for years. Also, it can be the result of constipation, a low fiber diet, and or poor hydration. Even stress or potty training can contribute to the condition. Risk factors of encaprices include low SES, a fear of using unhygienic toilets, living in a war-torn area, or child hospitalization for another condition. Other contributing factors are bullying, behavioral problems like depression or anxiety, and poor performance in school, which could also be a factor. In terms of psychological causes overall, when we're looking at elimination disorders, there are a few that stand out above the rest that I want to go over with you all. First, enuresis or encaprices can be a result of family problems, which usually arise when there's a lot of conflict or tension in the family. In those type of families, of course, the child is having trouble feeling safe or secure. They may have witnessed violence or been victims of abuse. These children tend to internalize their feelings and bottle them up inside. That can lead to an elimination disorder as they try to find a way to express themselves and release their pent up emotions. Another common cause are problems at school. So that can be bullying, child suffering from low self esteem or low self efficacy, and learning difficulties, and more. Children struggling at school may try to find ways to cope with that stress. And one way of doing that is through an elimination disorder. Unstable home life can include divorce, moving homes frequently, or having a parent with a mental illness. Those children as well can feel insecure or anxious at school, which can cause encaprices or enuresis. Another common cause of it is sexual abuse. It's one of the leading causes of elimination disorders in girls, and it's caused by having been sexually abused by someone. It can leave the child feeling scared, powerless, ashamed, insecure. And these are just some of the psychological causes of elimination disorders. There's also trauma, and this is encaprices or enuresis can happen when that child has experienced a traumatic event, such as the death of a loved one, witnessing or being part of some type of abuse. It can lead to them feeling overwhelmed and helpless. And as a result, they may try to find ways to cope with that trauma. And that can include elimination disorders. So now we're going to move on to sleep wake disorders, and that encompasses 10 disorders in this group. Those are insomnia disorder, hypersomnolence disorder, narcolepsy, breathing related sleep disorders, circadian rhythm sleep disorders, sleep wake disorders, such as non rapid eye movement, sleep arousal disorder. There's nightmare disorder, rapid eye movement, sleep behavior disorder, restless legs syndrome, and substance or medication induced sleep disorder. Sleep disorders or sleep wake disorders involve problems with the quality, timing, and the amount of sleep that clients get, which can result in daytime distress and, of course, a huge impairment in functioning. Sleep wake disorders often occur along with medical conditions or other mental health conditions such as depression, anxiety, or developmental or cognitive disorders. There are several types of sleep wake disorders, of which insomnia, as I'm sure you all have heard of, is the most common. Sleep difficulties can be linked to both physical and emotional problems, and sleep problems can both contribute or exacerbate mental health conditions and can be a symptom of other mental health conditions. About one third of adults report insomnia symptoms, and 6 to 10% meet the criteria for insomnia disorder. For the purposes of this lecture, we'll be going over the most common sleep wake disorders, those being insomnia, narcolepsy, nightmare disorder, and restless leg syndrome. So, starting with insomnia, this is one of, as I said, the most common sleep disorders that affects millions of people in the US. This often unrelenting condition can impact sleep in multiple ways, which includes difficulty falling asleep, difficulty staying asleep, waking up too early and not being able to fall back asleep, poor sleep. Studies estimate that between 10 to 30% or more of the worldwide population experiences insomnia. Now, I want to give you all sort of a look as I'm going through the slides. I'm going to put the criteria up so you all see. And whenever we're diagnosing an individual with any disorder, you want to make sure that they are meeting this criteria. I know that may sound silly to say during this time or at this point in the semester, but it is so important because a client could meet, A in one, two, and three, but they don't meet D, which is very important, meaning that the sleep difficulty is present for at least 3 months and the sleep difficulty occurs at least 3 nights per week. If it's 2 nights per week, if it's one night per week, they're not meeting criteria for this disorder. So it may not be insomnia. We might want to look at another disorder that could be similar to this, but it's not insomnia. So it's so important that you all are looking at these slides and also reading the DSM-5 TR to make sure when you're going through and you're looking at the different cases for your clients, that you can be sure they have the disorder. If they don't meet one part of the criteria, they don't have it. Remember that when you're writing your papers. Additionally, research can indicate that among people seeking primary care treatment, the prevalence of insomnia is as high as 69%. Lack of sleep and tiredness is known to contribute to many serious health concerns such as depression, anxiety, stress, high blood pressure, diabetes, obesity, stroke, and cardiovascular disease. Plus, the effects of chronic sleep of chronic sleep loss are cumulative. A key component of the diagnosis of insomnia is how a person's problems with sleep impact their daily life. Remember, we're always looking at functional impairment. Those functional impairments related to insomnia may include difficulty focusing on daily tasks, inability to get their work done. Irritability is a big functional impairment. There's also poor work performance, impaired executive functioning, daytime sleepiness, restlessness, and stress. Another interesting fact is that research also shows that people with insomnia often get more sleep than they think they do. However, for those with insomnia, the sleep they're getting may be less restorative than needed, and or the stress surrounding worrying about getting enough sleep creates an unwelcome self-fulfilling prophecy that erodes the sleep quality. Now, we always want to remember the specifiers. So you're going to look at if there's another mental disorder, including those substance use disorders, if there's another medical health condition, or another sleep disorder. You also want to specify how often these occur, if it's episodic, persistent, or recurrent. Insomnia also takes a toll on cognitive ability, as I said before, executive functioning. And if you all don't know what that is, everything we need to get the day going. Waking up on time, your ability to hold your attention, your emotion regulation, because we talked about the irritability, your ability to plan, to coordinate things, to switch the plan when things go wrong, things like that. It also takes a toll on working memory, um, mood, and just overall decision making. Research also shows that chronic sleep loss promotes negative emotional processing, which can also result in that anger, hopelessness, aggression, and extreme cases, suicidal ideation. Insomnia may be accompanied by a variety of daytime complaints and symptoms as well. Those include fatigue, decreased energy, and mood disturbances. Individuals with insomnia may appear either fatigued or haggard, or conversely, over aroused and wired. There may be an increased incidence of stress related psychophysiological symptoms such as tension headaches, muscle tension or pain, gastrointestinal symptoms. However, there are no consistent or characteristic abnormalities on physical examination. Symptoms of anxiety and depression that do not meet criteria for a specific mental health disorder may also be present, as well as an excessive focus on the perceived effects of sleep loss during functioning. Remember, insomnia can also be situational, so episodic, meaning that they last at least a month but less than 3 months. They can be persistent, 3 months or longer, or recurrent, two or more episodes happening in the space of a year. Now we're going to move on to narcolepsy. Narcolepsy is a sleep disorder that is characterized by chronic excessive daytime sleepiness, or EDS. It's a neurological condition that impacts the brain's ability to manage that sleep wake cycle. People who have this condition usually have a difficult time staying awake for extended periods of time, no matter what it is or what they're doing. The condition can also have a significant and serious impact on daily activities, since people feel overwhelmingly tired and unable to stay awake during the day. They may even be unwilling to fall asleep in the middle of activities, including driving or eating. I'm sorry, they unwillingly fall asleep during the middle of activities such as driving or eating. Narcolepsy affects approximately 1 in 2,000 people, although the condition is often believed to go underdiagnosed and undertreated. There are four common manifestations of narcolepsy. There's the EDS, or excessive daytime sleepiness. When a person has this condition, they'll experience a feeling of extreme sleepiness that'll cause them to fall asleep suddenly without warning. This can happen anywhere at any time. This means that the person can fall asleep in the middle of a conversation, while working, while playing, anything like that. In addition to these sudden sleep attacks, people can also have trouble concentrating or staying alert at times during the day, which is the primary symptom and is often the first to appear. The second manifestation is cataplexy. Cataplexy is a sudden, uncontrollable loss of muscle tone that affects the neck, face, and knees. It can be triggered by intense positive and negative emotions. It can vary in severity from mild to more severe. In some cases, people may only experience mild weakness that causes their head or jaw to drop. In other cases, their knees may buckle and they'll collapse to the ground. The third manifestation are hypnagogic and hypnopompic hallucinations. Hypnagogic hallucinations occur as people are falling asleep, and hypnopompic hallucinations occur as people are waking. People with narcolepsy also experience these very vivid sensory hallucinations that sometimes can be quite frightening. Also, there is the last one, which is sleep paralysis as a manifestation. When falling asleep or waking, people with narcolepsy may find themselves temporarily unable to speak or move. Such paralysis is usually brief and can last from a matter of a few seconds to several minutes. It's also very frightening for clients, but once an episode is over, people usually recover and they're able to move and speak. So, without treatment, narcolepsy can have a significant effect on a person's ability to function normally. It can lead to impairments in school, work, relationships. And in 90% of the cases, the first symptom to manifest again is that sleepiness or increased sleep, followed by cataplexy. Sleepiness, hypnagogic hallucinations, vivid dreaming, and REM sleep behavior disorder are the early symptoms. Excessive sleep rapidly progresses to an inability to stay awake during the day and to maintain good sleep at night without a clear increase in total 24-hour sleep time. In the first months of narcolepsy, cataplexy may be atypical, especially in children, manifesting with a generalized hypnotonia rather than with episodic emotionally triggered weakness. In general, narcolepsy symptoms remain fairly stable but may fluctuate with life events such as pregnancy and stressors. Exacerbations of symptoms suggest lack of compliance with medications or development of a concurrent sleep disorder, notably sleep apnea, which has been identified in about a quarter of individuals with narcolepsy. Now, the code that you're going to get for the type of narcolepsy depends on the specifier. Here are the specifiers here, and I'll go over some of the words that you might see in here. So you can see that there could be a hypocretin deficiency, and then criteria B1 are episodes of cataplexy, or B2, a low CSF hypocretin 1 levels, which will mean that G47.411 is met. So this is all about how doctors diagnose narcolepsy. There are two ways, two types of specialized tests that typically doctors use to diagnose narcolepsy. The first is the polysomnogram or PSG. That's a test where they place these electrodes on the scalp and they're looking at the electrical activity in the brain, the muscles, and the heart. Those doctors also look at your breathing so they can better understand the changes that are happening in breathing in the body while the client is sleeping. The PSG test can help doctors determine if REM sleep is occurring um, early in the sleep cycle, which is one of the key characteristics of narcolepsy. And then the other one is the multiple sleep latency test, or the MSLT. That test is conducted during the day following the polysomnogram. For that test, the client will be asked to take 4 or 5 naps spaced 2 hours apart during the day. The MSLT is designed to look at how quickly people fall asleep and how soon they can enter REM sleep. Onset of narcolepsy most often occurs in childhood and adolescence or young adulthood, but rarely in old age. Peak onset is around 15 to 25. It can be abrupt or progressive, with cataplexy developing over the years. Young children and adolescents with narcolepsy often develop aggression or behavioral problems secondary to sleepiness and or the nighttime sleep disruption. Workload and social pressure increase through high school and college, which reduces the available sleep time at night. Pregnancy does not seem to modify symptoms consistently. Um, However, after retirement, individuals typically have more opportunity for napping, reducing those need for stimulants. Now we'll go into nightmare disorder. So, of course, most people have a nightmare every once in a while in their life, but when those occur more regularly, it may be considered a nightmare disorder. Nightmare disorder is considered what we call a parasomnia, a type of sleep disorder that interferes with a person's sleep by creating abnormal or undesirable experiences. Nightmares only occur during REM sleep, which means they're more likely to take place after entering into a deeper sleep. I want to make a quick statement because I often hear my clients and just students and individuals um, not understanding the difference between night terrors and nightmares. I won't get into night terrors right now, but they are similar to nightmares. The difference being, though, they don't happen during REM sleep. So these nightmares or bad dreams are also different. Bad dreams are also different from nightmares because they don't cause the individual to wake up in a startled state. So getting back to nightmares, There are typically these lengthy, elaborate, story like sequences of dream imagery that seem very real and incite anxiety and fear or other dysphoric emotions. Nightmares typically focus on attempts to avoid or cope with the imminent danger, but may involve themes that evoke other negative emotions. Nightmares occurring after traumatic experiences may replicate the threatening situation, but most don't. Nightmares usually terminate with awakening and rapid return to full alertness. However, the dysphoric emotions may persist into wakefulness and contribute to the difficulty returning to sleep, and that can last, days or even weeks. Some of the possible causes of nightmare disorder um, are also some of the conditions that coexist with nightmare disorder. Those being PTSD, stress, trauma, anxiety, depression, suicidality, and BPD or borderline personality disorder. PTSD has been shown to greatly connect to nightmare disorder. A review of different literatures include many research studies that have found correlations between nightmares and PTSD. Additionally, nightmares related to a traumatic event are associated with more severe PTSD symptoms. PTSD can also predispose an individual to other psychological conditions like anxiety or depression, and these neurological or mental symptoms can increase the likelihood of having nightmares. Both children and adults who have experienced early trauma have a history of altered sleep quality and nightmares. In fact, about 77% of individuals who overcome sexual assault reported some form of sleep disturbance, whether it be insomnia, nightmares, or sleep related issues that may affect breathing or movement. Now, again, we want to look at the specifiers of the nightmare disorder, looking at if it's during sleep onset with a medical condition, and then you want to specify the severity and if it's acute, subacute, or persistent. Nightmares often begin around ages 3 to 6, but they reach a peak prevalence and severity in late adolescence or early adulthood. Nightmares most likely appear in children exposed to acute or chronic psychosocial stressors and thus may not resolve spontaneously. Nightmares are more common during childhood, but also prevalent throughout all ages. And almost 20% of children who have a nightmare, it happens about once a week. Nightmare disorder is in about 2 to 6% of adults and is more prevalent in women than in men. Again, that connects or correlates with the types of traumatic experiences women are typically resorted to that men are not. And the highest peak of women, it is in ages 20 to 39. The likelihood of getting nightmares tend to decrease between the ages of 50 to 59. And by the age of 60, they're more consistent and there's no longer any gender difference. We also want to consider culture when we're looking at nightmare disorder. One culture related issue is that the significance attributed to nightmares vary from culture to culture. And there are some sensitivities to beliefs that may facilitate disclosure in terms of if it's a nightmare or not. In several cultural contexts, such as in American Indian veterans and Cambodian refugees, also among Indonesian Civil War survivors, nightmares may be viewed as an important indicator of the individual's spiritual status or the condition of those who have died. So we want to make sure that we're always paying attention to those cultural aspects and considerations when we're going to diagnose a client with something such as this. And then lastly, we're going to look at restless leg syndrome. Restless legs syndrome, or RLS, is also called Willis-Ekbom disease, and it's a neurological disorder that affects how messages are sent from the brain to the legs. It causes an uncontrollable urge to move the legs, which is usually accompanied by feelings of discomfort. People with RLS often find it difficult to sleep, and as a result, can experience fatigue during daily activities. Well, there is no cure for RLS, um, but there are some treatments such as medications and lifestyle changes that can help manage the symptoms. Additionally, understanding what triggers the symptoms may also be beneficial for clients in reducing the severity. Some of the common triggers include alcohol use and certain medications. Treatment typically focuses on eliminating those triggers wherever possible and relieving any underlying medical conditions. For example, people with iron deficiencies may benefit from taking iron supplements. Symptoms of RLS can be both physical and psychological. So it's important to recognize the signs for our clients, and it's important for them to understand what could be happening in them. Below is a we'll have a list of the criteria that needs to be met for restless leg syndrome, and I also want to give you some of the common symptoms. There's an uncontrollable urge for the client to move their legs due to uncomfortable sensations such as tingling, pulling, creeping, and crawling. Symptoms are worse in the evening and night when lying or sitting down for long periods of time. Another one is moving around can temporarily relieve the uncomfortable sensations, but symptoms usually come back when the client stops moving. They also interfere with the sleep and cause difficulty getting comfortable while sleeping because there's a lot of kicking and moving around. And in extreme cases, constant movement of the legs can lead to exhaustion and depression due to that lack of sleep. There are two types of RLS, there's primary and secondary. Primary RLS is caused by an unknown factor, while secondary RLS is due to a known cause, such as a medical condition or a medication. The typical onset of restless leg syndrome is 20 to 30, and approximately 40% of individuals diagnosed with RLS during adulthood report having experienced symptoms before 20 years old, and 20% reported having experienced symptoms before the age of 10. I want to make another note one last time. Make sure when we're looking at the criteria for a disorder, the client is meeting all criteria, not just one or two, or what we may socially think is the case of a certain disorder. There are going to be times where you'll have your clients come in and complain of certain symptoms or certain problems. And especially with elimination and sleep wake disorders, it is very, very commonplace and professional to have the opinion or the direct approach with their medical doctor in terms of being able to consult with them about their client's medical conditions or even about if these conditions or issues are coming up on a day to day. As you saw with some of these disorders, you need a medical doctor's expertise, for example, with insomnia, when we look back at those specifiers. So remember, it's always helpful to consult with their primary care physician in order to get a more accurate diagnosis of any of these elimination or sleep wake disorders. That will conclude the presentation, and thank you for your time.